morning, everyone, and welcome to today's PHO webinar presentation, Substance Use and Gender-Based Violence, Strategies and Resources. My name is Dr. Sarah Carsley, and I'm Applied Public Health Specialist at Public Health Ontario, and I have the pleasure of co-moderating today's session. Before we begin, I would like to acknowledge and respect the land, sky, and waters of Ontario, including for their contribution and sharing to support all life within. I acknowledge and respect the treaty, unceded, and traditional territories of all First Nations across these lands and waters. I would like to acknowledge that I am in Toronto, on the traditional territory of many nations, including the Mississaugas of the Credit, the Anishinaabe, the Chippewa, the Haudenosaunee, and the Wendat peoples, and is now home to many diverse First Nations, Inuit, and Métis peoples. Please join me in acknowledgement and respect of all Indigenous peoples, their life journeys, and worldviews. May their wisdom always guide our own paths forward with open hands, open hearts, and open minds for the mutual success and benefit of all in Ontario. I will now mention some housekeeping items. To ensure an engaging and optimal experience for all, the Zoom chat and audio-video features have been disabled for this session. Please feel free to submit any content-related questions in the Q&A function at the bottom of your window. They will be addressed during the discussion period. For technical issues, please email capacitybuilding@oahpp.ca. I would now like to introduce my co-moderator for today's session, Dr. Susan Jack. Dr. Jack is a professor at McMaster University's School of Nursing and is a leading voice in public health nursing. She develops and evaluates interventions to improve maternal, infant, and family health. As head of the Public Health Nursing Practice Research Education Program, PHN PrEP, she advances research, practice, and education to drive meaningful change. Thank you so much for being here. Welcome, Susan.
Great. Sarah, thank you so much for that welcome. Thank you to the whole team at Public Health Ontario for supporting us with the technology to deliver these webinars, and welcome everyone. On a personal note, it is such a privilege this morning for me to welcome and introduce first Dr. Colleen Varcoe, who is a professor emeritus at the University of British Columbia in the School of Nursing. And Dr. Varcoe has been a mentor to me for so many years, and her work continues to shape how I think about nursing, equity, women's health, gender-based violence, and how care is experienced by the people that we serve across different systems. And many of you may recognize Dr. Varcoe's name or recognize her work. Colleen has been a nurse scholar for a long time whose thinking, I really believe, has shaped how many of us practice, how we teach, how we lead in nursing, how we care. She, for example, she has co-written the foundational textbook on relational nursing, helping us to articulate why relationships are not just an extra in nursing, but really central to ethical, effective care, and that our practice is shaped in the between, that relational space where meanings and power and possibilities emerge between nurses and clients and families and communities and teams. Colleen has also been responsible with her colleagues and co-writers for really shaping our thinking beyond trauma-informed care to thinking about trauma and violence-informed care, adding both the small v and the big V, challenging us to really see how, I would say, structural inequities and power and systems shape people's health experiences. She's been a co-principal investigator and a PI on really seminal Canadian studies that have developed and rigorously evaluated nursing interventions to support women at or around the time of leaving abusive relationships, reframing this work as health promotion, not crisis response alone. And most recently, she co-edited with one of our past webinar speakers, Dr. Nadine Wathen, the first handbook on trauma and violence-informed care. Oh, I've got my blur on. And this is a great handbook if anyone is ever interested, bringing together scholarship that many of us now rely on in practice, education, and research. And ultimately, her work aims to decrease inequity and violence, including interpersonal and structural forms of violence such as racism and stigma related to poverty, pain, and substance use. And her research also includes studies of the risks for and health effects of violence and promoting health for women who experience violence, especially Indigenous women. And this morning, it has been such a privilege to meet her colleague, Nancy Lipsky. And Nancy works across research, community engagement, and systems change to reduce stigma and structural inequities in health and social services. And she spent over a decade at the Women's Health Research Institute managing health equity projects before joining Equip Healthcare. And I imagine today that Colleen and Nancy are going to share a lot of resources with all of you around Equip Healthcare. And if you're not familiar with the website or resources from Equip Healthcare, I hope by the end of today you're online accessing those resources and checking out the incredible work that has been done by Equip. And Nancy now manages national knowledge mobilization initiatives that support the implementation of equity-oriented and trauma and violence-informed care. So Nancy and Colleen, welcome. Thank you for sharing your expertise today with public health nurses and others who are joining us who work with pregnant individuals and families with young children who are often experiencing very complex life situations, including experiences of violence and the use of substances. So thank you very much for joining us.
Thank you so much, Susan. That was very kind. A lovely introduction, and I so appreciate it. I've so appreciated your support over the years. I don't know who's mentoring whom. And just welcome to everybody. Thank you for attending, and thank you for caring about this topic. Nancy, if you don't mind going to the next slide, please. I would just like to echo Susan's thoughts about the lands that we're on. And we're just in a very, I think, unsettling and difficult and challenging time in the world. And I just noticed last night, I've long sort of thought that if we could learn from Indigenous people, from our elders everywhere around the globe, but in Canada from Indigenous people, we would be far better off. And just for example, I've always been struck by the fact that the Nuu-chah-nulth word, the Nuu-chah-nulth people are on what's now called Vancouver Island. The word for tree in Nuu-chah-nulth, it means landholder. And if you just think about what that might mean in terms of climate change and how we treat the forests, I think there's a lot of wisdom there. And last night I noticed that the executive director from the women's shelter in Haida Gwaii, her signature has a word, a Haida word that I won't try to pronounce. I've never heard it said, but it means we help each other live lives of kindness. And man, I think we need kindness today in this world. So I'm just going to leave you with that thought. Could you next slide, please, Nancy? We just wanted to flag the fact that, of course, we're going to be talking about violence, and we are going to be trying to be trauma and violence informed. But you folks who work in delivering care every day see hard things, and we're going to be talking about hard things. And we just want to say, please engage in ways that are good for you. I do want to make a little bit of a flag. I'm really trying to get us to stop thinking about burned out and really start thinking about used up, because I think where a lot of our trauma comes from is not hearing secondary stories from folks we provide services to, but from the brick walls that we keep bashing into in terms of trying to get support for folks. So what we're hoping to do today is really draw attention to substance use and its intersections with gender-based violence. You have fabulous resources available to you through the PHN on intimate partner violence and other forms of violence. And today we're hoping to zero in on the intersections between violence and substance use and to provide you with some resources. So we want to talk a little bit about the impacts of that intersection on health and well-being. And then our big goal is to put our resources that we've been working on in your hands for whatever purposes. Many of you are probably teachers, mentors. So however you would see fit to use our resources, that's what we'd like to encourage. Next slide, please. So this is just a brief outline of what we're hoping to do within the next little while. We want to give you a little high overview of our work and what we're going to be talking about, and then ask you where you are at so that we can get a sense of who we're talking to, and so you can get a sense of one another as well. Then we're going to share with you one of our first resources that we've been creating in the current project we're working on. It's an animation, and maybe have you put your thoughts in the Q&A or in the chat as we've shown it to you. Then return to talking to you a little bit about some of the foundations of the understanding we're trying to support related to the intersections between gender-based violence and substance use stigma. And then we'll shift over to sharing a couple more specific resources with you. And then what we're really hoping for toward the end is more of a dialogue where we can get your thoughts and provide some conversation. So next slide, please. Okay, so I just want to give you just a quick Cole's notes on the work that's behind this, because we're going to be sharing resources with you, but there's a whole, not just a single program of research, but multiple programs of research. And this is just showing you sort of my conceptualization of the work that myself and many other people, including Susan, who you just heard from, we've been working both at the structural level and at the interpersonal level. So myself and many of my colleagues have been conducting research primarily from a nursing lens, focused on violence and violence against women, and looking specifically at the challenges for Indigenous women, for women living in rural contexts, and then gradually have worked toward, and this is under the leadership of Dr. Marilyn Ford-Gilbo at Western, an intervention to support individual women who've experienced abuse. And we've piloted that, we've demonstrated effectiveness, and we're now really trying to scale it up throughout Canada if we can. We've also created an app, if any of you don't know about it, and the QR code is there, an app that can support women who are experiencing violence. And at the same time, we've been conducting studies on inequities and how is it that healthcare can mitigate inequities. And so we've done a whole range of studies on that, and then tried to support organizations to provide what we call more equity-oriented care. And so most recently, Nancy and I were working on a project called Equip Pathways, which was really focused on substance use and how to really reduce the stigma related to substance use. Next slide, please, Nancy. The issue with substance use, we often get really focused on the drugs or the alcohol or whatever the substances are, but really the big challenge is the real big barriers to well-being really is about stigma. And so that's what we've been aiming to do. So all along we've been focusing on, well, what does it take to provide equity-oriented care? And in my view, this is the route to promoting population health. We have to be providing more effective care tailored to people who are least likely to receive effective care if we really want to improve the overall population health. And we've identified that there's three key dimensions to equity-oriented care. You see those in the corner there. We believe that they are interconnected. We have to have trauma and violence informed care, as Susan mentioned, but you can't have trauma and violence informed care unless you have cultural safety. And from our point of view, that means taking a stance against racism and stigma and discrimination. And at the same time, our approach to substance use has to be really equity oriented. And by that, we mean not just harm reduction, but really aiming towards substance use health. And I'm going to say a little bit more about that. We think that any of these places is a good place to start. And we're constantly aiming not just toward improving the healthcare experiences of individual people that we provide care for, but also the well-being of care providers. And we think that we have to have both those things if we're going to have health equity, if we're going to have better population health, and if we're going to actually reduce costs, because we often are aiming at efficiency without paying attention to effectiveness, and it just gets harder and harder for healthcare providers to do their good work. Next slide, please. So the focus on substance use, I think, is absolutely crucial. We are, as everybody knows, in a huge crisis related to substance use. And here in BC, it's particularly devastating to people. And I'm talking about people who have died, people who are struggling on a daily basis, their families, care providers. We've really got a crisis level situation. And so we really want to focus on how we can mitigate some of these risks and treat people with more compassion, basically. But we've been doing a project recently that some of these resources have come out of that really works with the gender-based violence sector. So we're trying to support them as well, providing better care, because they are so poorly funded and constantly sort of struggling to provide sufficient care. For example, women are turned away, thousands of women are turned away from domestic violence shelters every day. And so within that struggle, we're trying to focus on substance use and figure out how to provide better approaches. Next slide, please. So this is the project that we're bringing resources to you. We've been working in partnership with groups in 3 provinces, British Columbia, Ontario, and New Brunswick, and we're partway through. We're going to be showing you resources from that project. And we've been working with, in British Columbia here, a couple of different organizations, the Ending Violence Association of BC, the Kamloops Sexual Assault Center, and the West Coast Community Resources Center on the far coast of Vancouver Island. And we've been focusing on how do we provide better services in the gender-based violence sector. So that's where these resources have emanated from.
In the next few slides, I'm going to expand upon the foundation that Colleen provided, and I'm going to hone in on this project, the Equipping the Gender-Based Violence Project for Substance Use Health project, and start sharing some of the resources from that project. We'll get a little bit of your input when we share the animation in a few minutes. So this slide here, what you're seeing is the invitation that we sent out to potential partners, those being community-based organizations working in the gender-based violence sector, to solicit expressions of interest for partnership on this project. So it was quite a journey to put out an open invite to organizations that some of us weren't familiar with, and to work with a brand new set of people. And it has been an absolutely incredible experience. And so what you're seeing here is what underpinned our approach, which was taking a principles-based process of co-design, where we were co-leading with a variety of community-based partners. And through this slide here, you're seeing what the potential community-based partners received. And this was distributed by the Ending Violence Association of BC across the province. We received quite a few responses of interest in partnering on this project. We were only able to work with 2 organizations, and as Colleen mentioned, those were the Kamloops Sexual Assault Counseling Center, and the West Coast Community Resources Society. So as also Colleen alluded to, the West Coast Community Resources Society provides more of a rural and remote perspective, whereas Kamloops Sexual Assault Counseling Center provided more of an urban perspective, which we thought was central to ensuring the applicability of the resources that we undertook co-designing with these partners. I'll note here that we provided approximately 10,000 in funding to each site to support their participation. And I'll also add that right from the outset of this project, these partners have been both foundational and transformative to this work and really led the directions that we've gone in. And that also includes even in the broader information sessions we had with community-based organizations about this potential partnership. And we heard clearly that there were unique challenges when interfacing with the healthcare system. And there was an interest from the gender-based violence sector participants that we spoke with in having the resources go beyond the gender-based violence sector and really cross over into other sectors, including healthcare. So it's really wonderful to be able to broaden the circle with you all today. So the first resource that we worked on with our partners was an animation, and we had received the input from previous partners, specifically CAPSA, formerly known as the Community Addiction Peer Support Association. And CAPSA had had a lot of success with creating animations as a form of a communication tool and an advocacy tool. So from that, we have become animation producers in collaboration with many supporters and partners. And we decided to kick off this project also with an animation. And this was in response to both the need to get both figuratively and literally on the same page with partners and build consensus on a variety of complex questions, and also to create an entry point to the other resources. So this serves as somewhat of a backgrounder about the intersections of gender-based violence and substance use and stigma. And it follows the story of someone named Anna and then broadens into a journey through care and the experience that Anna and many others have, and takes a look at our systems and what shifts we might be able to collectively make. And this animation also responded to partner interest in having more advocacy tools. The gender-based violence sector is already doing a lot of amazing work, and advocacy was identified as a key priority in really amplifying and strengthening the work they're doing. So we're hopeful that that will serve this purpose and may be useful in your work. And this slide you're seeing here gives a little deeper dive into the process. So as mentioned, it was a co-design and a co-leadership model, and we engaged in an iterative relational approach to storytelling and design. And what you're seeing here is one of the draft storyboards. And what you're not seeing is that we rewrote this fairly brief script more times than we can count at this point. And we got into every word with a variety of partners collectively rewriting the script until we felt really that we had concisely and clearly in a thoughtful way discussed the considerations around gender-based violence and substance use health in a way that would be relevant to a variety of audiences. And I'll note, even with the storyboards, our partners looked at every single image, and whether it was discussing whether a plant should be in the ground or in a potter planted, or if it was something more substantive, like how can we meaningfully and respectfully in a trauma and violence informed way represent the experience of stigma that someone may go through. We are co-presenting learnings with partners, and we have been sharing this animation. It's about to go live imminently, and you'll be one of the first audiences to see it. And so as I see the capacity team has put in the chat, for this portion, we're actually going to open up the chat. We would love to hear any thoughts that come up for you, questions, new learnings, or any action this type of animation might prompt. And I'm seeing in the chat, someone is saying hard to see anything. I'll just confirm, is there an issue with the visual? And as we resolve that, we'll ensure that that's clearly visible when we get to the animation so you can all see this well.
Someone's saying that the pictures are too small, but maybe if we play the animation, it'll take up the entire screen. Yes, we're just seeing the slides now. Thanks, Susan.
Right.
So let's play the animation.
Thank you. Okay, so this is approximately a 5-minute animation, and I'll look for a bit of confirmation that the audio is coming through well, and we'll look forward to seeing your thoughts in the chat. We won't be able to respond to everything, but we're excited for you to be able to see each other's responses, have some discussion, and we will respond to a few select comments afterwards.
Imagine a woman, let's call her Anna. Anna has decided to get help after years of abuse from her partner. Lately, she's been using alcohol and opioids to help with the overwhelming pain and fear she feels. Anna thinks she needs to leave her partner to be safe, but she also knows there are risks that come with leaving. She's terrified about what will happen to her children. Anna is ashamed for having stayed so long and for using substances to make it through the day. Cut off from family and friends and a community of care, she feels lost and unsure. How can we best support Anna? The relationships between gender-based violence and substance use are complex. Some people use substances as an excuse for using violence or to control their partner. Many people, like Anna, use substances to help deal with the impacts of violence, but we often blame them when they do. How we think and talk about violence and substance use impacts how we care for people. When violence is seen as the uncommon actions of a few people, we overlook how being abused or controlled because of your gender is part of everyday life for many people. When we dehumanize people who use violence, we overlook that many experienced violence themselves, and we close the door to real change. If we view substance use as a personal moral issue, we might support misconceptions like substance use causes violence, it excuses violence, and even that people who use substances deserve abuse. These ideas lead to stigma and shame and prevent people from seeking help. And when they're excluded from services, the consequences are serious. Together, we can imagine a better future. What if services were based on understanding that many people use substances to manage and reduce the emotional, spiritual, and physical pain arising from trauma? What about seeing substance use as a spectrum with a range of risks and benefits? What if we assumed that a person who uses violence might also have experienced violence? We could even have conversations about substance use health in the same way we talk about physical and mental health. There are so many encouraging possibilities, and it's up to us to collectively transform how health and social services are offered. Consider how trauma and violence-informed care can guide services by putting safety, trust, and choice first, using strengths-based approaches, always with the focus on ending all forms of discrimination. What if we started by recognizing the strengths of people who have survived violence and followed their lead? Meaningful support happens when you meet people where they are, with information, workable options, and realistic choices, including about their relationships and substance use. Trying to control people's decisions will drive them away from services, and having expectations of outcomes will keep them from coming back. Collaboration is key. To make sure policies and practices address the relationships between gender-based violence and substance use, people with expertise about violence, substance use health, and the law are all important. People with lived experience of both gender-based violence and substance use stigma are needed to provide direction. Effective services will recognize that many people experiencing violence may turn to substances to survive overwhelming experiences, often at the cost of their safety and health. We can use language, policies, and practices intentionally to make services safe and welcoming for everyone, regardless of the nature of their substance use. This includes staff who will have diverse experiences and understandings of violence and substance use. When we put people at the heart of every service and every interaction, we open the door for real connection and meaningful change. Through systems change, community collaboration, small shifts, and step-by-step progress, we can create new approaches and pathways so that people like Anna can find support, safety, and well-being. For more resources to support substance use health for people experiencing gender-based violence, please visit equiphealthcare.ca.
Comes to a close, we'll invite you again to put any thoughts, reflections, learnings, or ideas of how this may prompt to action into the chat.
Thanks, Nancy. And thank you for the comments that I can see. I see that someone has asked the very important question: Are people excluded? Are individuals excluded from shelters if they are using substances? And the answer to that question is yes, sometimes and often. And this is exactly why we started this project. Is folks from the gender-based violence sector recognized that they needed stronger, better, more equity-oriented approaches. And so we were approached to try to strengthen through creating some resources and getting on the same page. So I want to say that policies vary depending on the organizations, depending on their resources. And as I said at the outset, a lot of organizations and services are very under-resourced in the gender-based violence sector. So it's, when you're having to set priorities, sometimes it's easiest to go with folks who are the easiest to provide services to, or for whom you have the best resources. And so this is exactly why we're trying to strengthen the substance use health approaches. Thank you very much for all of the comments that I'm being able to see. And I appreciate that people are saying that it feels inclusive because we've worked really hard for that, and we're trying to walk that fine line between being inclusive without ever wandering into the space of stereotyping or for example, linking substance use to particular ethnicities. That's has been very important to us. And I see somebody else has commented on the fact that we focused on both people using violence and people who are experiencing violence. So I wanted to comment on people using violence. I think that's a very important thing that someone has flagged in the chat, because those are not people using violence and people experiencing violence. Those are not categories that are mutually exclusive. So, in our society, we have a lot of empathy, I think, for children and children experiencing violence. But as many of you know, when you've experienced violence, there is also a chance that you will use violence. And yet we really rely on, I think, demonizing people who have used violence and then treating them without any kind of compassion or understanding. So a child who may have experienced horrendous abuse as a child then becomes an abusive person or uses violence later in their life, that understanding seems to disappear. And yet, if we're going to decrease violence, we have to decrease violence throughout our society, also focusing on people who use violence. So yes, we were trying to convey a message that we want to attend to people who use and people who experience violence in their relationships both. So Nancy, did you want to make any more comments before we move on to the next slide?
Just to thank everyone for the responses. We're very early in sharing this, so it's just wonderful to be able to share this with you and to see the comments that you've shared. And I do see someone has asked about whether the video is on YouTube. So we just got this final cut. The video actually came through yesterday, so it's eminently will be launched, and we'll look into a way of getting that to you. And otherwise, it'll be on the Equip website.
Yeah, and when it's on the Equip website, please just help yourself and use it wherever you think it would be useful. So some of the key ideas. So while we're doing that, we really would love you folks are experts in public health. If you would like to share any thoughts in the question and answer um, regarding how it could be useful and how the ideas, not just the animation per se, but how the ideas could be useful in public health, that would be great. I'm just going to refer to a couple more of the question and answer comments. The first question is, will it be available in other language? The answer is yes. We want to release our French version as soon as possible. We don't have funding to do other languages, but definitely French. And any rabble rousing folks can do to say what languages would be helpful will help us in seeking funding to get things translated. And someone else has mentioned the CAPSA video and its emphasis on substance use health. And I think that is really helpful because there's resources on the CAPSA website that would also be very helpful. Someone is saying, in conversations about alcohol policy, I'm often advocating and educating about the link between alcohol availability and increased population level harms. Yes, and do we have recommendations on how to demonstrate the link between alcohol availability and violence? The issue of availability and policy aren't really the focus that we've taken, but there certainly are people who have focused on that. And just for example, there's been really good research showing that the liquor store distribution in certain areas, for example, around reserve communities, was very much part of the kind of the colonial project, really providing exposure to alcohol, facilitating that exposure to try to continue to pacify Indigenous people. So I think that those links, there is evidence there, and yeah, it's a really important comment. Somebody else has said, what language in practice quietly assigns blame and supports the moral model view? Yes, that is so excellent. We have to be asking ourselves that and actually pointing out those moral judgments and the idea of substance use as a moral failing and trying to problematize that. Really appreciate that. We're wondering if somebody else is saying, wondering if the approach includes the use of elders, traditional knowledge keepers, teachings, and other cultural resources. Absolutely, absolutely. And in our own communities and everyday work, I think that is, as I said at the outset, a really important strategy. It's not just for Indigenous people, but learning from the wisdom of the elders, I think can help us all have a more peaceful world. The dissemination plan for the video is we're going to put it up on our website. We're going to do as many webinars as we can, and we're going to invite you to share it widely. Yes, another really important question, is the term violence being used inclusive of all forms of violence? And absolutely. One thing that I'll say, and I'll ask Nancy to go to the next slide right now, please. One thing I'll say about that is that often with the women that we've worked with, and we've worked with thousands of women in our research and our practice, people often find that the world focuses on obvious physical violence, and really discourages emotional, mental, gaslighting, all those forms of abuse that are more invisible and don't have necessarily a physical evidence. really dismisses those experiences. And I think that's absolutely crucial that we bring that into the foreground. You know, bruises and lacerations and those kinds of things can heal, but the emotional effects, the mental health effects of ongoing trauma, stay with us for a long time, especially when they're unaddressed. So I just want to draw attention to CAPSA's vision of substance use health, and we're really trying to say, can we treat mental health, emotional health, physical health, substance use health on the same plane in a destigmatizing way? And can we really understand that everyone has a relationship to substances, and it ranges from no use at all to use that really impacts your health. But we really want to try to destigmatize substance use and promote health wherever people are at. So, as somebody mentioned in the chat, CAPSA has some really great resources to help not just understand that better, but tools to use with people you're providing services to, people you're teaching and mentoring, and so on. Next slide, please. So we're trying to draw on this idea of substance use health and really move away from an abstinence-only model. Abstinence is obviously part of substance use health for many people, but we can promote health at wherever people are at along that spectrum. And I've been trying to really get out of my vocabulary the idea of addiction, because it's a kind of an overused term and misused term. And we use it in common language, say, oh, I'm so addicted to X, Y, or Z. And it really waters down that idea. And often the problem that people have in terms of their health and well-being related to substance use is less about the actual physiological impact and more about the political, legal, and stigmatizing associations with substance use. So people commit crimes in relation to substance use because of poverty, not just because of the substance per se, for example. So what we're trying to do in promoting the idea of substance use health is focus on the fact that people's systemic conditions and lack of choices are highly problematic to promoting their health. And we have a dominance of the idea that substance use is a disease, but substance use is something that we learn, and we can learn different things. And so there are people who really argue that a lot of what we see in terms of the research on the brain and substance use is that it's not a disease per se, as we think of cancer, for example, but rather a learned behavior, if you will. And somebody mentioned in the chat about the moral view, and that moral view, it's supposed to be outmoded, but it's still alive and well in terms of stigmatizing people who use substances in ways that are visible or really negatively impact their health. And of course, as you folks will all know, that understanding gets applied differently depending on people's gender, their presumed ethnicity, and so on. So we're really trying to encourage using the idea of substance use health and really engaging with people who are using substances to guide how practice should be enacted. So next slide, please. So in terms of specifically women experiencing violence, and that's who we've done most of our work with, there's all these barriers to well-being, health promotion, getting health care. Stigma and shame are at the top of the list, but then there's all of these other issues that we try to address in our practice. And what I wanted to do is just also show you on the next slide that many of those factors are the same issues for people who are using substances or are assumed to be using substances. And I just want to emphasize again that, you know, I don't identify as an Indigenous person, but my biological father was Indigenous. So I grew up on the north end of Winnipeg. Well, I actually never grew up, but visibly Indigenous. And I have to say that that was a very good learning experience because no one can tell me that substance use stigma and racism aren't a daily experience for many, many people in this world. But these barriers that affect women who are experiencing violence also are similar to the barriers for people who use substances in ways that harm their health or assumed to be. And top of the list there too is stigma and shame. So as healthcare providers, this is what I think we have to really push against. And there's so many women that aren't getting help because of the fear of their children being apprehended. This is one of the most difficult and most challenging things in practice related to women experiencing violence and people who are using substances in ways that are harmful. So these are some of the barriers that we're trying to tackle and support you to tackle. Next slide, please, Nancy. So some of the top key considerations that we're trying to, or misunderstandings that we're trying to sort of address is the idea that substance use causes violence. And that is not the case. It doesn't cause violence. Substance use is often a factor in violence being used in a relationship, but it is not the actual cause. So when you think it causes violence, then the sort of the follow through on that is it also can be used to excuse violence. And we want to push back against both those things. The dynamics of substance use and violence are very complex, and we often have pretty simplistic understandings. And we use substance use in our society as often a victim blaming kind of strategy. So we're trying to move away from that and understand that that substance use plays a very complex role often in relation to people's experiences of violence. It can be used as a tactic of abuse within a relationship. And I'm just showing you this study that we did years and years ago, where we were focusing on Indigenous women's increased risk of HIV. And there was this sort of assumption that somehow it was related to drug use or, needles and so on. But what we found when we were working with women is that coercive sex was often part of the picture of why HIV risk was higher. Women were forced to use substances, or substances were withheld from them, or they were being trafficked to purchase substances and so on. So, I think we have to really have a much more complex understanding of the diverse interrelationships between substance use and gender-based violence. Next slide, please, Nancy. So I just want to say a little bit more about pain. And, we know that people who experience violence have high levels of chronic pain. That, whether we're talking about child maltreatment or we're talking about women experiencing violence or, any form of violence, pain is often associated with violence. But we often don't put pain in our understanding when we link it to substance use. So I think that, like somebody commented in the chat, let's go beyond understanding violence as something that is physical. And then if we understand pain as something that is also emotional, related to our mental health and so on, we often treat pain as legitimate or not legitimate. And legitimate pain is pain that you can see a physiological cause for. But if we go beyond that and understand that often substance use is a way of managing one's pain, then we can often shift our understanding. Now, I'm not saying that all substance use is about managing pain, but pain is often at the center of this intersection between trauma and violence and substance use. And all of those things are stigmatized. And I just want to make one more little comment about suicidality. Dr. Patria Taylor at the University of New Brunswick has really shifted my thinking around suicidality as also a way of managing pain, that a person can think, this is an option. I have that option if my pain becomes too much. So seeing suicidality as a way of managing pain begins to help us understand that when folks are using substances where they know it's going to be harmful to their health, they know there might be a chance that they could die, it's actually perhaps better to understand that as a way of managing pain. So just a little note on that. Next slide, please. So what we are trying to do is really bring trauma and violence informed care, bring substance use health understandings into the idea of trauma and violence informed care. So if we take a trauma and violence informed lens, as Susan mentioned at the outset, to this idea of substance use, then we would start looking at both our approaches to practice and organizational strategies and policies, understanding that substance use can be a tool of abuse, as I mentioned. It can excuse violence or a strategy for managing pain. Like if we have that understanding, then we would base our practices and our policies a little differently. And then if we take the principle of emotional safety and physical safety in environments, then we would provide services that are based on people at all levels of substance use. And somebody in the chat earlier asked about policies that exclude people from shelters and other services, counseling services, for example, when they are not abstinent or when they are using actively. So if we could shift those policies and provide care to people at all levels of use, then we would be addressing the needs of those who are least likely to get services. And if we take the principle of choice and collaboration, then we would really emphasize following the lead of the person. And I just want to give a little anecdote here. The people that we've worked with, women that we've worked with in our iHeal intervention, we never tell women what they should be doing in terms of their substance use. We do try to ask them what their health goals are and what they want and where they want to start. And it's been quite amazing to see the extent to which women, when they are supported in a non-judgmental way to follow their own health goals, actually end up reducing their substance use. So, currently in Alberta and BC, we've got, I'm not sure Ontario, we've got this idea that we're going to provide mandatory treatment for people for substance use. And yet, people who want treatment, people who want detox can't get it because there simply isn't enough services. And we know that mandatory treatment doesn't work. So really in your own practice, in your policies, in your settings, really trying to support people to identify and pursue their own health goals. To me, that's the way to success. And then finally, and I appreciate somebody noting that the strength-based approach to that animation, we really think that focusing on people's strengths and their successes is the way to go. Okay, next slide, please. So I'm going to now turn it over to Nancy to share a couple more resources with you, and then we're going to hear from you. Nancy, over to you.
Great. Thank you for those foundations, Colleen. So in the next few slides, I'm going to hone in on different resources that in partnership with many different organizations and people including people with lived expertise of gender-based violence and substance use stigma that we have put together through the EQUIP team, and would be keen to have you uptake as useful in your work. So the first is called the Nexus module, and this builds on the slide that Colleen shared about the intersections with pain. So the Nexus module focuses on the nexus or the intersections of trauma, violence, substance use stigma, and chronic pain. And this online course that's available on the EQUIP website, free of cost, invites social service and healthcare providers to consider the perspectives of people experiencing both substance use stigma and pain. And the course also gets into intersections with experiences of violence as well. And the intention was to bring a structural understanding to these intersections, and also to understanding well-being of people coming for services and people providing services. I've got a quote from the course down at the bottom here, which I found particularly powerful. And it says, "Research shows pain is poorly recognized, underestimated, undermanaged, and stigmatized." And I know Colleen has been hoping to create this course for quite some time, recognizing the importance on bringing attention to these intersections and supporting the provision of care at these intersections. And I know for myself, it was a really great opportunity to deepen my own learnings and learn from others. In particular, I really appreciated the content that helps unpack some of the history of substance use policy and stigma and the roots of stigma, as well as looking at some of the roots of the drug toxicity crisis and different approaches to care that can help reduce some of the harms related to the ongoing drug toxicity crisis. On the next slide, I'm going to dive a little deeper into the course to give you a better sense of the course and help situate if you'd be interested in taking the course. So it has 7 sections, and those sections focus on chronic pain, trauma and violence, implicit bias and stigma, equity-oriented approaches to care, and then closes on taking care of yourself while taking care of others, or while caring for others. And we actually, once finalized the course, rewrote this chapter to really ensure that it was bringing a structural understanding of well-being that looked at the systemic factors that influence the well-being of people providing care, the structural, organizational, and didn't focus on individualized approaches to well-being or type of bubble bath only approaches. And so I think it's a powerful note to close the chapter on, and was a good learning for me, and I hope for others as well. In terms of features, there are quite a few features. We're hoping that it's an interactive and engaging experience. There are reflective activities throughout, videos with experts, and on the right-hand side here, we have some experts with lived expertise of pain that shared their voices and insights very powerfully. There are case studies and also a learning simulation, which you can see a little bit of on the bottom right of the screen. And so that's a video-based learning simulation where you choose different pathways, and the video takes you down different pathways based on your response options. And the person in the simulation is a nurse. And really the purpose of that simulation is centered on substance use health and approaches to care that promote substance use health. The course has a certificate of completion. It takes approximately 10 hours to complete, done at your own time. And I'll note another quote from the course, which is, "Pain is personal, complex, and most of all, real." On the next slide, I'll close on the Nexus module by sharing just a course snapshot so you get a better sense of what the user experience looks like for this course. And the snapshot is from a cultural safety section of the course. So next, from the Equipping the Gender-Based Violence Sector for Substance Use Health project, this resource you're seeing imaged here is one of the first resources that we've launched from the project. And I think it's a great starting place. It's called Putting Language into Practice, Conversations about Gender-Based Violence and Substance Use Stigma. And so in the consultation process for this project, we'd heard from people, that they really wanted to get language right. There were sometimes concerns about using the wrong language, and recognizing that language is always evolving. We wanted to ground ourselves in language as we started this project. And so this resource has 4 sections, approximately 5 pages, And the first page is about guiding principles that can be considered when having a conversation and bringing an equity-oriented lens to that conversation about gender-based violence and substance use stigma. The second section provides a bit of an avoid this, try this. So it goes through different terms that might be stigmatizing and provides alternatives. For example, Colleen was talking about addiction. So we provide some alternatives, for example, offered by CAPSA around substance use health concern or substance use and a variety of options that people might find helpful. And we then have a section on intersectional considerations, which really helps bring that intersectional lens to the fore, how gender-based violence and substance use stigma intersect with other forms of stigma and discrimination, and also does a little bit of myth busting in that section. And finally closes on a very practically oriented section about bringing the guiding principles from the outset into action in your conversations. So that has some language prompts that could be used when having conversations about gender-based violence and substance use. And it also has a section I really appreciate at the end. It's a bit more meta and helps us take a step back and reflect the why of why are we asking about certain questions or not, and what might be the implications. So an example there would be around whether to ask around someone's substance use. And then there's also a variety of examples provided about a way to do that that can be more equity oriented. So that's live on the Equip website, and I see the capacity team has shared that in the chat. And finally, through this project, we are creating a wide variety of resources with project partners. And so here we're just giving a bit of a look into a few of them. So I'll give you a high level sense of what some of the other resources to come are. So in addition to print-based resources like the language prompter you just saw, there is a podcast series that's being currently, I think it's just wrapped recording, and it's called Doing Hard Things Together. And it's about really helping generate some community and sharing voices of experts across Canada about their work surrounding gender-based violence. And it's done with a CBC affiliated reporter, and we're really keen to get that out to folks. This will be released this year and available on the Equip website. And we also became game designers through this work. Fortunately, we actually worked with someone who does game design and has a lot of expertise at the intersections of gender-based violence and substance use stigma. And then with partners, we developed a game, and it's called Glimmers, and it's about strengths-based narratives and strengthening capacity to use strengths-based language. And I'm really excited about this game because it's a unique opportunity to try and enact learnings from the different resources that are available, both from Equip and beyond, and to really embody them in a community-based way with your team or your organization. So it's a card-based role-playing game where people introduce a scene, and then once they introduce the scene, participants identify strengths, and then they reintroduce the scene using strengths-based approach. So we're excited to share that soon. It's currently being play tested. The animated videos will be live in English very shortly, and then following that in French. And Doctors Nadine Wathen and Susan Rogers are leading a course on trauma and violence informed care and gender-based violence, with also sections on substance use health that will also be released later this year. And they're doing that in partnership with many community-based organizations out of Ontario. And finally, the Equip team has an equity action kit available on the website currently. And that's for teams and organizations that might want to do a more substantive undertaking around implementing equity-oriented care. So there's a roadmap, different paths you can take to tailor to your interests, and a lot of resources that are brought together in that action kit to support implementation of equity-oriented care. And so what we'll be doing is taking all the resources through this project and weaving them through that action kit to strengthen its relevance to gender-based violence and substance use intersections.
Thank you so much. That's great. Nancy, did you want to summarize the poll a bit, or do you want me to just share what I quickly saw in the response to your last poll?
Yeah, please go ahead, Susan.
Well, I was thrilled in the first question that 99% of the individuals who responded to that last poll said they learned something new. So thank you so much. And I think even one of the most critical learnings from today is just an awareness of these resources. You know, a webinar today provides us just a short snippet of time to become cognizant, increase awareness of new concepts, of thinking about links between violence and substance use, thinking about the term substance use health, which may be new to people, as well as an awareness of where to go for new resources. And for individuals who are part of organizations or health units who are on the call today, I do encourage you, and particularly if you're in a role of leadership, to look at, it's like you read my mind, to take a look at the Equip Equity Action Kit, the toolkit. As I've been doing this work, one of the learnings that I've come to appreciate is that we can support individuals, individual family home visitors, individual public health nurses, to think about some of the skills and competencies and knowledge they need to deliver care that is underpinned by the principles of harm reduction or trauma and violence informed care, or to approach clients with humility. And, you know, individual practitioners can alter their language, can approach clients with curiosity, focus a good use of their time on building relationships and offering choice. However, I think that unless an organization at a team level or a public health unit is also not committed to looking at their programs and services from these lenses, and that there's not a commitment within policies, procedures, strategic plans to deliver equity-oriented care, it can be very difficult for individuals to carry the flag to do this work. So I guess what I'm saying is that the work needs to happen at both levels. Individual practitioners, there's a lot that all of you can do and adapt in your work with the clients that you connect with. But it's really important that organizations start to look at, are these the types of programs and principles that we want to underpin our services with? And I think that Action Toolkit provides some really powerful questions, a starting place for teams and organizations to think about, how do we do this work at the organizational level and really speak the language. So thank you for sharing those. Now we're going to jump into some questions. And in looking at the questions, I'm really glad that Nancy and Colleen are here to answer these, because I'm looking at some of these questions going, whew, I'm eager for the answer as well. I'm going to start with one of my own questions. And I appreciated that you put up the resource to language, supporting, again, individuals. Don't say this, think about saying this instead. And very often, as a nurse educator, when I'm working with students in their practicums or working with teams across the province, there is still an awareness that some individuals, when they're working with people who use substances, they may roll their eyes, they may use stigmatizing terms like addict or frequent flyer. So you've provided a resource to support individuals, such as myself or other nurses, on how to reframe the language. But if I'm the nurse educator, or I'm working with a colleague, and I hear a colleague say those terms, how do I call attention to that in a TVIC nice way?
I'm going to start and see if Nancy would like to jump in. Excellent question. We've been working with that question on racism and other forms of stigma as well forever. And we actually built on another person's work to try to say, it depends on your context, it depends on your power relation, lots of things, which of course you know that, Susan, but so are you going to use humor? Are you going to use correcting, or what exactly is the right approach? So we have a set of cards that actually do that and say, here's some ways to respond to discrimination of any form, and think about your context, think about your power relation, and then choose this. And here's an example of how to do it in a respectful way that is corrective, Like say you're a nursing instructor and you have a student, and that this behavior isn't okay. So there's ways to do that that are respectful, right? And then there's other, it's your colleague or it's your boss, very different. How are you going to do it? So we have examples that work in almost all contexts. So using I statements such as, I'm really trying to get the language of addiction out of my vocabulary, right? I used that already earlier in the presentation. So sometimes that works, is just saying, I'm trying to think more thoughtfully about XYZ or whatever. So that's just a few, but there's probably about 10 different genres, if you will, with examples. So just encourage people to have a look at that and practice them. And the game that Nancy was mentioning, we are trying to get people to play with it a little bit, so it's not so heavy and difficult, but trying to get in, and you wouldn't believe, people just kill themselves laughing and clapping and laughing and carrying on when you actually get people to practice it in a fairly non-threatening way. So those are just a few thoughts. I don't know if Nancy had anything to add on that one.
Yes, thank you, Colleen. I think I would just build directly on what you're sharing and say that uh, overall supporting a culture of co-learning where people are encouraged both to teach and to learn. And I really received that in a meaningful way from the community action team in Vancouver. So they're an organization, it's a beautiful coalition of service providers and people with lived expertise. And they're working to reduce the harms of the drug toxicity crisis in Vancouver. And that has just been a real powerful learning to me. They open the space with shared agreements and a consensus around the culture of their shared space. And I think that's just been so powerful in creating a space in which people can both explore each other's language and their safety to make mistakes and also to learn and to teach.
Great, thank you. And hearing both of your responses, then I know many teams join these webinars. It may look like one person, but I know that there's many teams out there that are in a group watching this together. It sounds to me like some of these games, these cards, creating that space as part of a collective might be a great activity to do at a team meeting. So thank you for sharing those resources. I'm going to go back to one of the questions around language while we're talking about language. And the question is, what language in nursing practice or in practice quietly assigns blame or supports this moral model view? And I'm wondering if this question is about helping nurses illuminate to themselves or reflect or be aware of what might be some of the things that they're not aware that they're saying that might be perceived by a client that there's a moral judgment being put on their use of substances.
Mm-hmm. Well, again, I'll start. I think often we don't know when we're conveying judgment. We don't mean to be. And I think for me, I'm fond of saying I don't believe in woman-centered care. I only believe in woman-led care. And so I think that at the outset, if you care and you convey that, that will go a long way in building trust. And if you work on the trust end of it, it less matters what you say. So when I'm working with a woman, for example, I will say, like, I don't necessarily know what's important to you. Could you help me out here? And if I approach a person with humility and a willingness to listen to them, and a meaningful, I don't mean just lip service to it, but a meaningful willingness to follow their lead, it less matters what I say. So I think there are all kinds of things that are just in our everyday language, and we're tripping ourselves up like when we're doing this work, we're getting tripped up on ourselves and getting called on to shift our language all the time. So I think what I'm saying is it's not like having a playbook or even a lexicon of things to say, right ways to speak, but it's more about that relationship and building trust. I don't know if that would. Susan, can I just go back to you said having those conversations in your organizations. I think I just would like to put a plug in. We have these these tools that are called Rate My Organization tools, and they are discussion tools. And they are fabulous for getting conversations going. So we have, for example, one called Rate Your Organization on Harm Reduction. And what you do is you just sit around and everybody on their own gives a whole bunch of questions, and you give a rating for your organization, and then you share it with one another. And it's not a right or wrong, and it's not really rating your organization. It's just a way to get a conversation going. And if I had one recommendation, I'd say every team do that, to see where you're at, not just as an organization, but as individuals. So, Nancy, did you have anything to respond to Susan's question?
I might just add, I think also how people understand, how we respect someone's own personal understanding of their own substance use, right? And try and not put upon our own understandings of substance use on others. So some people we've spoken to over the years see different substances that they're using as medicine, for example, and also respecting the way that they might self-identify in relation to substance use as well.
Great, thank you. Okay. Is normalizing screening about health risks? I'm going to ask you to think about specifically then screening about substance use, and certainly giving you some context within the Ontario home visiting programs as part of universal postpartum screens done in hospital. I believe there are a single question that may screen or ask about the use of substances. Public health nurses for families who are identified at risk do a more in-depth assessment where there are maybe one or two questions, or there's other questions screening for substance use very early in home visiting programs. So giving you a little bit of that context, is normalizing screening about health risks, e.g. substance use, a way to decrease stigma and sharing resources?
I'm going to jump in again. Screening. Well, I think it matters how things are done. Obviously, Susan, you already know how I feel about screening.
Yep.
I think screening is a way to deepen stigma in general. I also know that people are following the mandates of their organization, and they have to complete ticky boxes. But there's many ways to do that. What are we trying to achieve with screening? Using the example of screening for intimate partner violence, it's been shown very clearly in research that screening per se doesn't do anything. It doesn't accomplish anything. In some instances, it can be done in a harmful way, but most importantly, it doesn't accomplish anything. So, what are we trying to accomplish when we're screening? And I think we need to look at at what is the ultimate goal. The ultimate goal is to provide better and more effective care. And so, if we're thinking then about substance use, then we are trying to provide better support related to people's substance use. So if we were leading, what is the message we're leading with? Or we're leading with, I would really want to support your health, and what is it that I need to know to support your health? That's not a screening question. That's I'm following your lead question. Is there anything you're concerned about? So again, I'm going to go back to the nature of the relationship and the building of the trust. So if I was in the position where I had a organizational mandate where I was required to screen, first of all, I would be pushing back against that. I would be saying, if I screen for X, what have I got to follow up with? What resources am I providing? What care am I providing? What is the consequence of that screening going to be? That would be my first thing, is that I would be working on the organization to, rather than screening, providing effective services. To me, that's most important. But then the pushback against that is, well, how do you know who needs services? I'm going to assume that everybody needs services. So if I'm in relationship with somebody who's experiencing violence, I'm going to be saying, you know what, people have all kinds of ways of trying to cope with this impact. You need to tell me a little bit about how you're dealing with this. And if I think that this is appropriate, I will obviously bring up the conversation, but bringing up a conversation is very different than screening for something. So I don't think it's a blanket yes, no answer. I think if somebody is being focused by their organization, by a mandate to do a thing called screening, then focus on it, but focus on it in a health promoting, non-stigmatizing way. I know that's not a very satisfactory answer. Nancy,
No.
can you bail me out here?
I think
it's a great answer.
Yeah, I think it's a great answer as well, and this is where I wish we were in a room with the 200 plus attendees, because I do think there are organizational mandates and provincial forms and movements towards, in a first or second or third home visit, let's ask up to 2 screening questions. Coming from a place of intent to identify individuals who may be using substances so that nurse home visitors, public health nurses can identify who might need that focus topic. There's so many topics to talk about in home visiting and how best to support them. But I think, Colleen, what you've highlighted is a different approach to achieving the same goal. Maybe instead of that screening language, it does start with, well, it always starts with building a therapeutic alliance. I think we can screen out the yin yang, and if people don't trust us, we're not getting the truth of the situation anyways. We'll get data for the organization, so there's a checkbox there, but we might not truly know their health needs. So I really appreciate and challenge health units to think about then, on ongoing home visits as the relationship is developed, to start, and I'll have to go back and look at the transcript, but what do I need to know about from you to support your health? And then a second maybe layered open-ended question around coping. What do you do under these stressful situations, or how are you coping with X, Y, and Z? And then maybe as necessary, and nurses are assessing and observing so many different things, leading to a more focused open-ended question of curiosity and wonderment. Maybe after introducing the concept of substance use health, we all use substances. I've got, my tea this morning, which has caffeine, which is a substance, and sort of normalizing how we all use different substances and then opening up a conversation there. Would that be a more, I don't know, it's hard to know.
Well, also depending on the context, but I think that in introducing a relationship, especially if you've got an ongoing relationship, different than if you're just episodic, right? In, saying, over the course of the next X, if you have an ongoing relationship, next set of visits, there's so many things we can talk about, and I want to go with what's important to you. So I know that lots of people use substances, for example. Lots of people think about suicide. Lots of people actually have problems with eating, or they bury themselves in their food, or they can't eat. There's so many different things that we could talk about. And so putting that out there without asking anything and leaving the person to lead, to me, is a much more satisfactory and effective approach.
Great. Oh my gosh, so thank you. So that's a very powerful way. There's so many other questions and we could talk for hours, but I think letting the individual and the person lead is a very strong way to end. So Nancy and Colleen, on behalf of PHN Prep and Public Health Ontario, we would just like to thank you so much for joining us today and sharing your wisdom. Many of the questions are about access to resources, so I encourage everyone to go to the links that have been shared with Equip Healthcare. As a reminder to everyone that there will be a survey sent out following the webinar, and to please complete the survey. It really helps us think about future topics through PHN Prep. And know that all of our webinars are archived, and you could go and view those on past PHO sessions. There's a link provided, or as well as on PHN Prep. We do have another incredible webinar in February that is going to be a gift to family home visitors and public health nurses and all of you who work with families. And Colleen, you started this saying, let's not talk about feeling burnt out anymore, but that people are feeling used up by the system. So we will have a speaker, Kristen Honey, who will be coming to speak to all of you about boundary work and essentially deep, meaningful ways to care for yourself beyond pizza parties and food within a system that uses people up. So stay tuned for more information about that. Thank you again, Colleen. Thank you, Nancy, and wishing everyone a wonderful and safe day. Thank you. Goodbye.